Yes, ma'am, we are live. We can begin.
Good afternoon, everybody. Welcome to this series of Vibrate. And I'm Dr. Sonia Malik here with you, talking to you today about luteal phase support. And I'm going to take you through a couple of cases in order to understand and to try and see whether we can do justice to this very difficult part of the menstrual cycle and an ART cycle whenever we are trying to collaborate with our patients. So, without wasting much time, let me just start and let you take you through this. So, as we all know, that the menstrual cycle is essentially two parts: the follicular phase and the luteal phase. And the central point of this is the ovulation, which happens once the follicle ruptures, and then there is a structure called the corpus luteum which forms, and that is what is responsible for the changes which take place in the endometrium or the uterus where the embryo is going to implant. So this corpus luteum is a beautiful structure, less talked about because basically we have just started to think more about it. And if you look at the physiology of the corpus luteum, we know that there are two kinds of cells, the theca lutein cells and the granulosa cells. And it is actually the theca lutein cells which are responsible for the corpus luteum activity. And this is where they react to the extraneous LH and the HCG, and there is a production of progesterone from there. Whereas the granulosa cells are not that, they do not react that well. Yes, they do have some kind of an action. The LH does have some kind of an action as well over there, but then it is purely the theca cells which are responsible for whatever we are seeing in the luteal phase. So we also know that there is the first part of the menstrual cycle is estrogen predominant. There is more of estradiol secreted over there as the follicle is growing, and hence the changes that take place in the endometrium are purely related to the estrogen. But when the progesterone starts to come after the corpus luteum forms or when the ovulation takes place, that is also known as the window of implantation, as you all know, and that is the time when there is a progesterone dominance in the menstrual cycle. So this has always remained a controversy. We really have been talking about luteal phase defect all our lives. We've heard of it, but yet we are not convinced that there was something called a luteal phase defect. And for the first time in 1949, Georgina Jones first described it. And since then, and it was actually described as a deficiency of the secretory transformation of the endometrium, which resulted because of a deficient progesterone production or a progesterone exposure, an inadequate exposure to progesterone. So both of them gave rise to a dysfunctional or a defective endometrium. But this was a controversy. Why? Because it was seen that in 30 to 3 to 20% of infertile patients, it was present in as high as 5 to 60% of RPL, it was reported. But in also 6 to 10% of the fertile population, we were getting this luteal phase defect. So, hence, for a long time, we were not convinced that there was something like this present all over. But then gradually, from different models that have evolved, one, the contraceptive only pill, and second, the donor recipient cycle, which gave us a chance to study the endometrium so carefully and to see what are the effects of estrogen and progesterone on the endometrium. We came to know that there is something which is happening over there in the second half also, which needs to be controlled. And we got to know that estrogen is actually responsible for endometrial proliferation and progesterone and the upregulation of progesterone receptors. But it is the progesterone which has a higher role, a bigger role to play. That is luteinization, dehydrogenation, downregulation of the immune system, endometrial receptivity, and the opening of the window of implantation. It is also responsible for the muscle contractility of the uterus, so it slows down, it makes it more relaxed. So these are all the things that were happening, and hence we also realized that there are lots of markers of uterine receptivity which got to be known. And we also knew that now there are three kinds of markers which will tell us that the endometrium is receptive or not. These were the signaling markers, which are going to, the markers which tell the endometrium that the blastocyst is approaching. Then the classical markers which get upregulated for the apposition, in attachment and invasion into the endometrium, and finally the molecules which are actually involved in the cellular differentiation. So we got to know all this over a period of time. And in 1994, the NIH started a huge research product with different kinds of markers and different groups of researchers looking at the various predominant cell types, as well as their function to understand what is happening to the endometrium in the luteal phase or during the entire menstrual cycle for that matter. And finally, we found out that after ovulation, luteal phase is actually can be divided into two parts: the early luteal phase, which is from POD 6 to 10, and the later luteal phase, which starts from the 12th day to the 14th day, depending upon the various cytokines that are secreted, upregulated, or downregulated during this period, and later on, whatever is happening to the markers. That is what we got to know, and therefore we actually labeled the luteal phase into an early luteal phase and a late luteal phase, depending upon what are the molecular markers that are secreted over there. And hence, some clinical tests or maybe some commercial tests were also formed out of this. One was based on the integrin value and seeing the histology and comparing it with the integrins. And endometrium was divided into type 1 and type 2. However, this did not do very well. So we are no longer using this. But this one, which is now very, very popular, is the endometrial receptivity array, or the ERA, which is actually telling us about the window of implantation and the expression of 238 genes which are related to it. And it actually very, very specifically tells us what is the status of the endometrium, thereby personalizing the embryo transfer for us. So endometrial receptivity array, these recent studies, and all this has actually brought us to this conclusion now that there is definitely something called a receptive luteal phase and a dysregulated luteal phase. Therefore, LPD or luteal phase defect or deficiency is not something which is not agreeable. The consensus of literature now agrees that it does exist, and it is multifactorial. It could be because of abnormal follicular genesis, it could be because of an inadequate luteinizing hormone surge, or it could be inadequate secretion of progesterone by the corpus luteum, or finally, it could also be because of an abnormal response by the endometrium. So the problem could be at any level, the pathophysiology of this could be at any level, and the response could be at any level. Hence, we need to understand when we are dealing with our patients as to what is the problem and how we should be dealing with this particular part of the menstrual cycle. So other related causes could be because of hyperprolactinemia, which is a very common cause and known for a long time, hypothyroidism, which of course both of them can go together as well. And there could be secondary abnormalities in the presence of an otherwise normal ovarian and endometrial function. So an LPD could be found in a natural cycle, it could be found in a stimulated cycle, and that is how the complexity that arose from Georgina Jones' paper has actually now been solved, because we know that it can exist in fertile patients, it can exist in infertile patients because of various problems at various levels. And also that it does exist in normal life events as well. Menstrual cycles post-menarche or perimenopausal do have LPD, and similarly states of physical stress where athletes and training is happening, there again there could be a luteal phase insufficiency. In addition, dieting, recent childbirth, extremes of reproductive age, exercises, and unexplained infertility and hyperprolactinemia are the major causes of LPD physiological. Pathophysiologically, like I explained, it could be at any level, where deficiency of FSH will leads to poor follicular genesis, a high LH, hyperprolactinemia. All this could be leading to a problem with the follicle formation, and hence the whole cycle is disturbed. Again, then there could be ovarian defects per se, and this could lead to this could be as a response to the gonadotrophins, or it could be a response to any of the other medicines that we are using, giving rise to a poor corpus luteum with no LH receptors, high prolactin levels within, and a poor vascularization, leading to a poor corpus luteum formation. Similarly, the endometrial defects could also lead to this kind of a problem, and we see endometritis quite commonly in our day-to-day practice. In the non-IVF stimulated cycles, it is the drug that can lead to poor follicular genesis, like we said, a premature or a blunt LH surge, endometrial hostility, or a poor or deficient corpus luteum. Whereas in the stimulated IVF cycles, it could be the stress of the procedure, the effect of the ovulation induction on the endometrium as well as the corpus luteum, the effect of oocyte retrieval on the luteal phase, or the inadequate luteal support that we are giving to these patients. So all this could lead to a problem and a poor outcome for the patient. So multiple ovulation induction in the COH condition produces very high levels of estrogen, and a poorly functioning corpus luteum may be because of the inherent poor quality of the oocyte, or it could also be a drug effect because of the COH. Oocyte retrieval, on the other hand, results in normal removal of granulosa cells from the follicle. We all know this. This is a very popular fact, and it deprives the resulting corpus luteum of the cells. So, therefore, it is a deficient corpus luteum. Natural cycle also can produce a lag in the endometrial development, and FSH-HMG cycles generally show an advanced development of the endometrium. However, most of this synchronous development, which is found in the IVF cycle, is attributed to the effect of the downregulation because of the GnRH agonist on the endometrium, and that is basically now supposed to be the most important part. In high responders, it is also the high estrogen levels which are responsible, and therefore we need an equal amount of progesterone to counter that. In poor responders, on the other hand, because there is a poor priming of the endometrium, it leads to a lack of estrogen as well as LPD. However, androgen levels also, if they are increased, they can also result in FSH stimulation. As a result of the FSH stimulation, can also cause a negative effect on the endometrium. So then we come to how should we manage all this complexity of having an endometrium which is not responsive because of many problems occurring either iatrogenically because of what we have done, or they may be inherently present within the patient. So it depends upon the diagnosis and patient profile, which could be a patient of infertility and RPL. It could be because of the cause of infertility and the type of cycle that we are dealing with. So there are multiple factors and multiple types, subtypes, which are actually there with us to handle, and we have to go and see what we can do. The patient profile also, as you can see, is different, is varying, and this I think covers nearly all the kinds of patients that we are seeing in our OPD, and therefore we have to understand that we have to deal with these separately as they come to us. So now we take the cases as they do, and let us take some examples and try and see what we can do for our patients, keeping all this background in mind. So this is a very simple patient of 25 years. She's married to a person called Ram, who's 28 years of age, and they have been married for the last 3 years, and they are consulting for an inability to conceive despite trying for that period. The appearance is normal. She's thin and she has a BMI of 21. The cycles are regular, and she had a period around 12 days ago. She doesn't remember her date exactly, but there is no significant past history. Family history is normal. Examination was normal. TVS shows a growing dominant follicle of 15 millimeter on the right side, and the other ovary is silent. The endometrium is triple layer. It's about 6 millimeter thick. So basically, from the look of it, this lady looks fine. And so we looked at the husband. The husband is also normal looking with no significant past history, but he's not very sure of mumps in his childhood. So we ordered a test after examining the patient, and the test was of semen analysis, which showed us azoospermia. Now, patient was suggested the options of ART after biopsy since the fructose was present, and AID, but they opted for AID because basically that was the cost was the deterrent. AID was done after establishing ovulation. Patient was given vitamins and asked to do a pregnancy test after 14 days. It came positive with a beta HCG of 250. So basically, this is just a simple case where it is not indicated to give any luteal phase support because this is more or less like a physiological cycle. The lady is normal. It was just a donor insemination, and basically just a donor insemination. And you all know that LPS in IUI in a natural cycle is not indicated because we are doing LPS in IUI. Sorry, we are doing IUIs in donor insemination for cervical factor infertility, mild and moderate male factor infertility. In these cases, suppose it is a donor insemination, it's not indicated because it's a physiological cycle. So, a systematic meta-analysis of IUI, which consisted of 5 trials and 1298 patients, which was done in 2013, it showed that LPS is beneficial to patients undergoing gonadotrophin cycles because of multiple follicular genesis. However, it is not so much required in CC cycles where there is a single follicle growing. That is what was the inference from this meta-analysis. Similarly, an RCT was conducted for IUI to see whether we should be giving any luteal phase support to such patients or not. This was inconclusive, and it said that the outcome of this randomized trial to control was actually telling us that there was really no difference between the control as well as the ones where it was given. There was really no difference in the pregnancy rate, the implantation rate, and the live birth rate. So it was inconclusive, and therefore, if you do not give, it is recommended presently that only if you have multiple follicles in IUI, you may give it. But if you don't give anything in a CC cycle or in a natural cycle, it's fine. You may get away with it if your hormones are normal. Coming to the second case. Now here, she's a 32-year-old lady from a tier 2 Indian town. She was referred for IVF for recurrent very early pregnancy loss. On questioning, she gave a very interesting history of infertility of 10 years. Each time she missed a period, she would start bleeding in 20 to 24 days. When this happened the third time, she consulted a gynecologist who did a beta HCG, which was positive. The pregnancy was supported with hormones, but it failed again. So she had short cycles, but whenever she missed a cycle, she would get a positive pregnancy, which would not carry on. So it was like a biochemical pregnancy. This happened 2 times last year. The pregnancy was supported by progesterone and HCG injections. Now, for the past 1 year, she was unable to conceive, and this was her main complaint. Menstrual and surgical history and family history were normal. The earlier menstrual cycles were 45 to 26 to 27 days, regular, painless, and the present cycles had shortened to 22 to 24 days, and it was a normal, otherwise normal, moderate flow. This time it was this patient had, this is an old file, so it was on 2010 instead of 20. So this is an old patient whom I have recorded over here. Basic investigations 5.6, LH3, E2 was E2 was 31, and prolactin was 21. And you can see over here that there is no record of the AMH because this is an old file. However, let's see what happened. So thyroid was normal, husband semen was normal, an ultrasound scan showed was normal, and a dominant follicle was seen that extruded between the 10th and 11th day in 3 fast follicular monitorings. That means whatever monitoring charts she had given to us, we saw that each time she was extruding on the 10th or 11th day, and HCG showed normal uterus and bilateral patent uterus. Now, what was inferred from her past history was that she had a long-standing infertility history of 10 years. She had short menstrual cycles, and she was ovulating early. On day 2 of her cycle, we ordered the following test. So a baseline was done, and then we also requested for all these tests. Okay. And then after that, what happened? When she came on day 5 to discuss her reports, they were all normal, and a provisional diagnosis of luteal phase defect was made, and we decided to make her go through another natural cycle before we actually embark upon some kind of a treatment. So when we saw her on day 5, we saw that she had already got a dominant follicle of 11 millimeter, and this follicle was therefore followed, and it also extruded at a small size of 16 millimeter on day 10, and the endometrium was okay. So now the serum LHE2 and serum progesterone were done on that day, and it was found to be 37, 108, and 1.9 nanograms respectively. She was advised natural contact, and considering that this was a poor follicle, hence a luteal phase support was started with 17 beta estradiol of 2 milligram twice daily and natural micronized progesterone in a dose of 200 milligram twice daily. After 17 days of support, the beta HCG was 630 and serum progesterone was 16. After 48 hours, HCG became 1960. However, she bled after 15 days and aborted again. Now, what was her problem? Where did we go wrong? How do you think this case should have been managed, and where did we go wrong? So probably the follicle was not good because she was always, extruding at small sizes, and also the E2 level was low when she had extruded. So probably, and therefore there was also a high LH at that point. So it was an early LH surge, probably also because she had small, short cycle. So therefore, it was decided that this probably we have to find out what is the cause for poor follicular genesis. So poor follicular genesis in LPD, as we know, is also results in LPD. So abnormal follicular development results from inadequate FSH and LH secretion from the interior pituitary. FSH stimulates the granulosa cells of the growing follicle to produce estradiol from the conversion of its substrate androstenedione, and a decrease in FSH release results in reduced granulosa cell growth and lower estradiol levels. Because the corpus luteum is not a de novo structure, but it is a direct result of the follicle. So it shows that if the follicle is defective, there is also a defective corpus luteum and hence decreased progesterone coming out of it, leading to an LPD. So what did we think? What do you think we could have done? We did some more investigations to find out whether where we have gone wrong. We looked at the prolactin because she had a borderline prolactin, if you can remember in the beginning, and high prolactin can affect both the FSH and the GnRH levels at the central level, thereby affecting the follicular genesis. High prolactin levels may cause LPD by affecting the corpus luteum function, and an abnormal prolactin can also affect the endometrial receptivity, causing an early pregnancy loss. So testing has to be done properly because there can be sleep dependent hyperprolactinemia also, which can lead to this corpus luteum problem. And we do have to find out what kind of a pattern this patient has, and we have to actually assess the prolactin levels in waking conditions in such patients. So in order to diagnose hyperprolactinemia, this is also another very interesting thing that I found, that women with periods, we should be measuring the prolactin and progesterone in the luteal phase during at least 2 cycles in order to actually ascertain whether this patient really has it or not. And in patients who have oligomenorrhea, we need to measure the FSH and prolactin on 2 different occasions. So CT MRI, of course, we all know should be performed if the hyperprolactinemia is too much. It can also be raised, as you know, in emotional and physical stress, in protein, if the patient has taken very high protein meals, intense breast stimulation, recent breast examination, recent exercise, sleep and weight cycle. So please remember that it has to be taken at a proper time whenever you are going to take your prolactin levels. So in the next cycle, what happened? This patient had a normal prolactin. We assessed the prolactin, it was normal. So we improved the follicular genesis by augmenting the cycle with letrozole because we were again worried about the endometrium, hence did not give a clomiphene, 2.5 milligram for 5 days, and it was started on day 3. Follicular rupture enhanced at size 22 by giving HCG 5000, and timed intercourse was advised, followed by luteal support of vaginal micronized progesterone. And a single injection of HCG 5000 was given on day 8 post rupture. A beta HCG after 14 days was 653, and a SAC was seen at 4.5 weeks. Progesterone was continued till 12 weeks of pregnancy. So this patient was essentially able to carry on with the pregnancy with this kind of a management. Now, why did we give an HCG? If you look at this chart, you see over here that when you give the HCG for trigger, it actually has its effect for day 8 or day 9 in the first part of the earlier luteal phase, and therefore the LH deficient period starts after day 8 in a normal cycle, and that is what may give rise to the weakening or the decrease or apoptosis of the of the corpus luteum, and the secretion of progesterone may decrease. So in order to do what we call as the supporting the corpus luteum, rescuing the corpus luteum, and HCG bolus is generally, it can be given around day 8 and 9 of the cycle. Otherwise, these cycles are supported with just progesterone. Coming now to the bigger part and the more important part, that is luteal phase support in ART cycles. Now, you know that the variables are many in ART cycles. It also depends on so many factors like even the cost of the medication. But most importantly, it depends, the type of luteal phase support depends upon the type of trigger that you're giving to the patient and the type of ET that you're doing, whether you're doing a fresh transfer or you're doing a frozen embryo transfer. It all depends on these factors. And we know that now we have 3 kinds of triggers. We have the HCG trigger, we have the GnRH agonist trigger, and we have something called the dual trigger when both these are mixed together and given to the patient. This could be in an agonist cycle, it could be in an antagonist cycle. So these are the variables that we have when we are looking at the luteal support, because these are the factors which are actually going to affect it for the luteal phase, because the follicular phase of each of these cycles is different. So, like coming on to another case, then Jasmine is a 36-year-old nulliparous patient with a husband Yusuf, who's 38. They presented with primary infertility of 4 years duration. After a complete workup, the couple was thought to have unexplained infertility. Jasmine had undergone 3 failed cycles of controlled ovarian stimulation with insemination. She underwent an in vitro fertilization cycle recently with GnRH antagonist protocol and a trigger injection of triptorelin 0.2 ml in view of the estrogen, which was 4,000 picograms, followed by ultrasonographically guided follicular aspiration. However, only 8 oocytes were retrieved, all of which fertilized and divided into day 3 embryos. 3 8-cell day 3 embryos were transferred under ultrasound guidance, seeing that there was no evidence of OHSS and presuming that the report may not have been correct. The other embryos were not good to be frozen, and no complications occurred with the treatment of this procedure. However, now, the question is that why do we think of luteal phase deficiency that warrants progesterone supplementation during all the assisted reproductive cycles? Before we go on to what happened to this patient, why were we thinking of supporting her with progesterone? So the factors that are responsible for this deficiency of progesterone, as I showed you in that chart earlier also, is that the LH support of progesterone formation of the corpus luteum is suppressed by the gonadotropin agonist. And the egg retrieval in IVF also removes a large quantity of granulosa cells, thereby decreasing the progesterone formation. HCG administration suppresses the LH support, and LH is suppressed by abnormally elevated steroids, that is estradiol, from multiple corpora lutea during a stimulated cycle. So these are some of the factors which together may lead to an aberrant luteal phase. Now, out of all these mechanisms, the development of the corpus luteum defect has disapproved a primary role of gonadotropin agonist, the destruction of granulosa cells during retrieval, or the administration of HCG. So the present consensus is that it is the excess production of hormones by the multiple corpus lutea from ovarian hyperstimulation which lead to a suppression of LH production at the hypothalamic pituitary level, leading to a poor corpus luteum formation. So basically, this factor out of the 4 factors that I outlined to you is actually responsible for the luteal phase insufficiency that is being caused in patients who are undergoing ART. Now, therefore, the emphasis has shifted from the loss of granulosa cells to the basically the deficiency of LH, which is caused because of high levels of the steroids. So LH, we all know, is also now known to play a very crucial role in the luteal phase, totally responsible for steroidogenic activity of the corpus luteum, upregulation of growth factors like VGFA and FG2, upregulation of cytokines which are involved in implantation, and the stimulation of LH receptors in the endometrium. So because of all this, the LH has a major role to play, and hence, if it is deficient, we are definitely going to have a problem. Look at this beautiful chart which tells us what is the mid-cycle LH levels that you would find in a natural cycle. It is about 6. When you give an HCG trigger, it is 0.2 at mid-cycle. And in a GnRH agonist, it is 1.5 at that point of time. So the P4 requirement during luteal phase of stimulated cycles is always greater than a normal cycle. That is what the inference is from majority of these studies. So how do you then support this endometrium? How do you support the luteal phase in such cycles? The studies where HCG has been compared with placebo or no treatment, it was found that HCG gave a higher live birth rate and an ongoing pregnancy rate with, of course, an increased risk of OHS. On the other hand, progesterone versus no placebo or no treatment gave high live birth rates with no other risk or any other problem. So therefore, progesterone is preferred as compared to HCG in majority of the cycles for LPS. That is the reason. This is a Cochrane database review of 2015, where progesterone has definitely been suggested as the molecule of choice for LPS rather than HCG. However, HCG also produces a good pregnancy rate. So now, one day after retrieval, Jasmine began vaginal micronized progesterone based on this premise twice daily. And on day 8 after her embryo transfer, she started to bleed, which was more than spotting. She was advised to keep taking progesterone vaginally and add intramuscular progesterone 50 milligram daily. Now we just stepped up the progesterone. On day 12, her beta HCG was 30. This value increased to 65 on day 14. However, Jasmine's bleeding had resolved on the third day of intramuscular progesterone. So basically, she had become better, and that is why she had shown a beta HCG positive. Ultrasound at 4 weeks revealed an intrauterine sac, but unfortunately, she had a spontaneous abortion soon after. And in addition to that, she also developed a gluteal hematoma at the site of intramuscular injections that was very painful, and she was very upset because she lost the baby and she developed an abscess. So now looking at the cause, what had happened? Where did we go wrong in this luteal phase support? So again, here the trigger was GnRH agonist, and it was basically an antagonist cycle with a GnRH agonist trigger. So as I told you earlier, what happens to the surge in cases of a GnRH agonist trigger? This is a natural surge which rises. There is a parabola, 14 hours it is steady, and then for the next 20 hours, so in 36 to 48 hours, it falls down. Whereas what happens with the GnRH agonist surge, it is absolutely sharp. There is a sharp rise in the FSH and LH levels. It is also the FSH which rises with the LH. There is a sharp rise, and then there is a sharp fall at about 20 hours. So there is a lot of deficiency which is produced later on. While in an HCG trigger, it goes like a parabola, and the HCG has a longer half-life. It remains in the blood for a longer period, as I had explained earlier, and it goes on till day 7 and 8. So that is the difference between the two triggers. This one is sharp. However, an HCG trigger does not produce any FSH, so it is supposedly now supposed to be less physiological, because in a natural surge, we have both FSH and LH being produced. In GnRH agonist, it is simulating a natural surge, but then the fall is very sharp. So the GnRH has a longer LH deficiency period as compared to an HCG period. Hence, the support has to be more probably, and also for a longer period. That is why we need to have a better support. But do we need extra support also? We shall see. And when you look at this trigger and you see for the prevention of OHSS, as was done, supposedly done in this case because the levels were high, this was basically, it shows that when you give a GnRH agonist trigger, it definitely brings down the possibility of having a OHSS. The incidence falls to 1.2. Similarly, the disadvantage also with an LH trigger, with a GnRH trigger, could be that there is a lower oocyte retrieval rate and fewer mature oocytes which are available for freezing, as we saw in this patient. Because if the basal levels, LH levels, are less than 2.2, then this is the single most differentiating marker for suboptimal responders. So in case you find that the LH of this patient was right from the beginning, it was very low, then in such cases, it is not a good idea to give a GnRH trigger. So in such cases, in order to increase the yield, we have started to give something called the dual trigger, which we will talk about. Similarly, when we discuss or see the difference between the two, we find that there is a definitely better outcome when you are giving support with both the luteal support is given with an HCG trigger and a conventional luteal support. The pregnancy rate and the miscarriage rate is much less. You can see over here that the miscarriage rate is much less. So to continue what we did to our patient, a few months later, she came back for a second cycle. This time we gave a trigger of 10,000, but we had given a very low dose of gonadotropins. We gave her a similar antagonist protocol with very low dose of gonadotropins and an HCG trigger. She had 8 oocytes this time and 7 fertilized. On day 3, we transferred 3 embryos. After a long discussion, because she had had a previous miscarriage and she had a bad experience with intramuscular progesterone as well, it was decided to give her vaginal progesterone and measure the progesterone levels more frequently in the luteal phase. And we also decided to give her a single shot of HCG on the 6th post-transfer day. Estradiol was also added as 4 milligrams. This patient had no bleeding, and then later on, she tested positive. At 6 weeks, ultrasound showed a fetal pole and a fetal heart also. 4 embryos that were performed later were frozen. Now, how do we justify the progesterone, the estrogen, and the HCG that was given in this patient? And what is the evidence on the routes of administration? Parenteral, there are 4 routes of administration of progesterone. How do we justify all this? Let us look at the evidence. So basically, regimes after HCG trigger and fresh transfer, if we compare between progesterone and HCG alone or along with progesterone, we find that there is no difference. However, there is a lower OHSS rate. Like I said, progesterone versus progesterone plus estrogen, again, there is no difference. And progesterone versus progesterone plus GnRH agonist also in the luteal phase, that it was found that it was lower progesterone only group. This gave us a better pregnancy rate. So again, 2015 Cochrane database. So according to the regime, according to the data, Cochrane database, any of these, any protocol, all of them give the same kind of result. There is really no difference. A slight edge is seen with the use of intramuscular progesterone, which is in these reports coming on later now. What about the advantages and disadvantages? Oral is extensively metabolized with low bioavailability. Intramuscular is effective but very less convenient because of the pain. And subcutaneous, we have few trials, but it is encouraging. Rectal is not widely accepted and there are hardly any trials. Vaginal is supposed to be very effective and as effective as the intramuscular injection, and it is self-administered, but again, it can be messy and many patients don't like it. So recently there was a review of the oral progesterone, dydrogesterone with these 2 studies, and it was found that this is equally efficacious as compared to the vaginal gel and the suppository in HRT. And also the recent studies on aqueous intramuscular progesterone are showing equal efficacy as vaginal suppository in ART. So therefore we have these 2 good options now in comparison with the vaginal estrogen as well as the intramuscular oil-based injection. So these are options which can be used now instead of the other ones. What about role of estrogen supplementation? The earlier reports have shown that with the addition of estrogen during the luteal phase, especially in patients where their GnRH agonist has been used, is effective and it should be given in such patients because it improves the pregnancy rate, implantation rate, and decrease the miscarriage rate. However, later studies have shown that there is no significant difference between the treatment group of any of the secondary outcomes, including the ongoing pregnancy rate, fertilization rate, implantation rate, and miscarriage rate. However, in a recent review of 2017, this shows that it does increase the clinical pregnancy rate, but there is no change seen in the live birth rate in such patients where estrogen therapy has been used for luteal phase support. Hence, the jury is still out. We still are not very sure of what we should be doing, whether we should be giving progesterone, estrogen to all our patients or selectively to some of our patients. What about the role of HCG? We know that like I said, we can give a bolus dose, but there are other methods also of giving it, like microdose HCG, which is given after that, and a luteal posting. We can also give it as a luteal support as a complement instead of giving progesterone because it helps to support the corpus luteum. And now, when a GnRH agonist trigger is given in a fresh ET, what was found was that, look at this chart over here, you see that all the papers in which some amount of HCG was given along with the progesterone, the pregnancy rate and the miscarriage rate is much better. The pregnancy rate is better and the miscarriage rate goes down if you're giving, say, 1500s of HCG and doing an OPU plus day 5 of Crinone. So progesterone plus HCG always gives rise to a better outcome. That is what has been shown. So therefore, the concept again of dual trigger to improve or enhance our reports came up. And this is where we are using a dual trigger in various ways. You are giving it with HCG, dual trigger HCG and the GnRH agonist trigger, low dose HCG at ovum retrieval, but the risk of OHSS is still present over here, or you give a low dose HCG in the luteal phase. This is a very small proof of concept study. 2 studies are there, but it is not conclusive. So when you're giving a dual trigger, it is either here when you're giving them both together, especially in the poor responders, because you want a better outcome. And of course, there is no risk of OHSS in such cases, or you're giving a low dose HCG at the time of trigger or at the time of embryo transfer because you are wanting to support your luteal phase. A word about FET, although I know that most of you attending here may not be doing it, but of course the ART specialists here would like to see, would like to know. So what is, this is becoming very popular now, and basically what we some of the facts about FET are that we need a thickness of at least 7 millimeter, which is arbitrary, of course. There are pregnancies reported with lesser and of course higher as well, but this is arbitrary. Hormone measurements are also questionable. We do not know what is the best estradiol and progesterone levels. Escape ovulation can take place in 2 to 8% of HRT cycles, and a vaginal progesterone similar to intramuscular is similar, but patients can prefer the vaginal route. Optimal mid-luteal progesterone is said to be 22 to 31 in this paper, but however, it is not yet settled. Intercourse may decrease the progesterone levels because of the vaginal administration, and progesterone duration till ET remains very debatable. When to stop also is debatable. What is also known about estrogen in FET is that if you give a short duration of estrogen, it is associated with a higher miscarriage rate. So you have to give an optimal estrogen of about 10 to 12 days in these patients. However, a long estrogen supplementation is also not detrimental. The type and route of estrogen has no effect on the success rates. Now, if you review this paper is a very interesting paper which tells us when you should be transferring. It is a very good guideline. So when you give the HCG trigger, and from there, how do you calculate when you have to transfer? So in a natural cycle, this is the time when the LH surge has begun. So on the 4th day of LH surge or the 4th day of ovulation, you are transferring a day 3 embryo. And on the 6th day of the LH, of the ovulation, you are actually transferring the day 6 embryo, day 5 embryo. So similar thing has to be simulated in an HRT cycle where the E2 supplementation continues and the first day of progesterone is taken as P0 and a day 5 embryo is transferred on the 6th day of progesterone because that is the time when the ovulation supposed ovulation had happened and progesterone had come into the body. So remember this, that one extra day of progesterone from what you are doing is from the day of the embryo development is the rule. So if it is day 3, 4 days of progesterone, and if it is day 5 embryo, then 6 days of progesterone. There is no difference in the birth rates from any of the techniques that you use for these. This is a meta-analysis where any kind of preparation for FET will result in the same kind of result. So to conclude, let us see then what is the status of the luteal phase support in assisted reproduction. This was a web-based survey where they found that there is a majority of the doctors are in favor of progesterone for luteal phase support. Overall, the addition of other substances such as estrogen and HCG did not seem to improve the results. The authors also did not find any evidence favoring a specific route of progesterone for these patients. However, progesterone therefore seems to be the best option for luteal phase support to get better pregnancy rates. And if you can see over here in the chart, you find that most of the RCTs are telling us that if you add any of these things, it's not going to be very helpful. However, when should we start it? So generally it is accepted that as a routine in ART, on the day of or 1 day after the oocyte retrieval, progesterone should be started. And when should we stop it? It is a common practice to continue it approximately for 10 weeks after the luteal-placental shift has happened. Can it be stopped earlier? 2 to 3 weeks after a positive pregnancy test also. And this Egyptian doctor Abu Galar, he is supposed to be the father, is also maybe discontinued as soon as a pregnancy test is positive. Whereas there are others where there is no CL, estrogen and progesterone must be continued until the luteal-placental shift. That is what majority of people are doing. But all of us here in our country are actually taking it up to 10 to 12 weeks. So what are the best practices therefore? Progesterone to be given depending upon the type of cycle, natural, IUI or IVF. LPS regime should be individualized according to the trigger. HCG trigger, you give progesterone alone, it is enough. GnRH trigger, you give progesterone plus HCG as a bolus or a low dose. Daily you can give. A modified LPS in a GnRH agonist trigger needs to be refined further. And HCG trigger and conventional LPS method is the method of choice for all eligible patients. Why eligible? Because if you are suspecting OHSS, you cannot give the HCG. you won't only give progesterone in such. FET, the decision it should be based on clinical experience and the patient's preferences as to which method to use, what LPS to use, but the duration of progesterone exposure and dosage might have an impact on the pregnancy outcome. Therefore, progesterone has to be started at the right time. The embryo transfer has to be done at the right time after the starting of progesterone. Estrogen exposure has to be at least minimum for 10 days or 11 days. With that, I thank you very much. And now I think we should be taking the questions. So let me go on and see what all we have. Can I be seen like this? Am I okay?
Yes, ma'am, you are able
All
to
right.
see.
So the first question is from Sarita Mumbai, who says ways to maintain a balance of progesterone in the luteal phase. So, actually, very good question and a difficult one also. The problem is that the progesterone levels are something which are very, very difficult to maintain and to assess more than anything else to assess. And especially if you are using a vaginal progesterone, you know that the serum levels are very low, and therefore you cannot really know whether what you are giving is correct or not. But they say that if you have a progesterone level of about 10 when you're using vaginal progesterone, then it is enough to maintain that pregnancy. Similarly, if you're using an intramuscular progesterone, say it is to the tune of about 30 nanograms, which is supposed to be present when you're using a intramuscular progesterone. So the balance will have to be maintained depending on the type of progesterone you're using and what is the route of progesterone that you're using. So that is how we generally look at this. What are the symptoms of low progesterone for women? It can be nothing except a little bleeding and a cramping that these patients may complain of. Many of them start feeling cramps. And if you step up the progesterone, as we did in one of the patients where she had this spotting, sometimes you feel that this spotting is because of the implantation bleed. But you have to remember when the patient is complaining of it. If it is past the implantation period, then probably it is because of a lack of progesterone that she's having, either the bleeding or the cramping. And if you step up the progesterone, then sometimes it helps, sometimes it may not help, and the patient may not show up with a pregnancy. So then Bhanu S. Delhi. Sorry, this question was from Seali from Pune and Bhanu from Delhi. Is progesterone support enough when ovulation is triggered with GnRH agonist? Yes, I think I did allude to that, and I did tell you that estrogen has to be added to that because it is not just enough to give a progesterone. You have to add estrogen plus progesterone when a GnRH agonist trigger is given. However, like I said, I showed you two other studies, and one of them was a meta-analysis, and the other one was a systematic review, which are both showing that some of the studies are favoring it, and some of the studies are saying that it does not impact your outcome. The pregnancy rate, the clinical pregnancy rate does increase, but the live birth rate and the rest of it does not change. So therefore, we are still not very sure whether we should be giving it or not. However, said that in my own practice, I feel that if we give estrogen along with progesterone, especially in the GnRH agonist triggered cycles, the patient does better and you get a better pregnancy rate. My own data says that. Mariam Ahmedabad, defects of luteal phase to be managed. I think, Mariam, we have discussed this in great detail, and I don't think I should be going over it again because basically it starts from the beginning, and I have discussed the natural as well as the induced kind of luteal phase defect which is happening and given you different scenarios where this can happen. Karthik from Mumbai, oral progesterone for luteal phase support. Yes. Karthik, yes, I did tell you in one of the slides that luteal phase support in its oral form is also very effective now. We know it. And the problem with the oral micronized progesterone was its bioavailability, because it was getting destroyed in the gastric mucosa. But now with better formation of the drug, and also with the presence of dydrogesterone, which is also another form of oral progesterone, we know that the results are very good. And dydrogesterone is equally effective as compared to micronized progesterone. The results of the Lotus 1 and Lotus 2 trials are showing that it is no way inferior to it. So therefore, any of the two can be used orally as well, because oral micronized progesterone is also working. Isha Gandhi, Mumbai. Ma'am, do you have an experience of using estradiol patches in LPS? Yes. Uh, we have had very little experience because these patches were available for a very short while. Now we do not have estrogen patches, but I have a lot of experience of using extra non-oral type of estradiol in the form of gel, as well as intramuscular estradiol. We were very, very happy with the intramuscular form, because it was giving rise to a very good endometrium formation, especially in the frozen embryo transfers. So we were preparing the endometrium with the patches as well as with that. So it does work, and it works very beautifully as luteal phase support. Luteal preparation as well as support. So, Dr. Somini, the preferred route of progesterone in your practice. Well, I think I am using a mixture of both dydrogesterone as well as vaginal progesterone in about 80 to 90% of my patients, where I have feel that I'm doing a minimal or a modified natural cycle, or something where there is minimal stimulation. There I'm using a single progesterone, and there my preferred progesterone is dydrogesterone, because it is easy for the patient to use it. So that is how I divide my progesterones. Shalini Katyar, Varanasi. Ma'am, in which cases beta HCG 5000 or 10,000 is preferred for rupture? If you have a single follicle, you only need 5,000. But if you have a multifollicular development, then you may need a higher dose. But we also know from our studies, and we also know from the recombinant that is available now, there we know that just 5,000 or 6.5 as it is over there in that recombinant, it is quite enough. It is enough to cause a follicular rupture. So therefore, you really do not need to give 10,000 and increase your risk of OHSS. 5,000 is more than enough. Kaira Vigokani, Mumbai. At what day should P4 levels be rechecked? Generally, people are not checking progesterone levels in the luteal phase, because progesterone levels are very tricky, and they really do not give us a lot of help. However, one progesterone level, maybe if you do it on the day of embryo transfer, or one day after embryo transfer, if you find that the progesterone levels are around 30, 36, then you are all right. You have given adequate amount of support, and your corpus lutea are performing well. You can do it. But however, having said that, we are not very sure of the progesterone levels. So you will have to form your own kind of criteria to check them, and to be able to say that this is my optimum, and this is where I get a good pregnancy rate with whatever form of progesterone you are using. Sachin Saha, Pune. Can we use progesterone support till 14 weeks? Majority of us in India are using it routinely up to 12 to 14 weeks of pregnancy. We are not very sure whether basically it is going to help us if we it is going to harm us if we take away the progesterone too early. Although many of the reports say that it is not required, but in India, all of us are little wary of it, and all of us are in routine using it up till that time. Anuradha Arora, can we add HCG with Dufaston for LPD? Yes, we can definitely add it. And how many weeks? Whatever is your protocol, whether you want to give it for 8 weeks up till the corpus luteum function is well established, or you want to continue it till 12 weeks, depends on what you want. You can definitely add it. Kiran Dua, thank you, Kiran. Thank you for this comment. I'm glad you enjoyed this presentation. And I think for now,
Yes,
there are
ma'am.
no
That's all
other
with the
questions.
questions.
Yeah.
So I'll request you for a short takeaway message for the doctors.
I didn't get the, sorry.
I'll request you for a short takeaway message.
Okay. Yeah. So basically, can I go on to a full screen? I'm not enjoying this. Okay, maybe 1 minute. No. Okay. Sorry, I don't know what I've done. Am I visible?
Yes, you are, ma'am.
Okay. So anyway, well, thank you all for being here today. I hope you have enjoyed this, and for you all, a learning lesson is that please do not ignore the luteal phase. More than anything else, I would request all of you to have a look at your corpus luteum. Try to also recognize this as an organ that you have to see after you have done an IUI. If you look at the corpus luteum once you have done an IUI, you will recognize that there are different kinds of corpus luteum also. Some of them are good and some of them are not good. So the good corpus luteum is the one which is, which is uh, kind of fully blown up, and it has a very good vascular supply. So such a corpus luteum is not going to be deficient in progesterone. It is going to give you a good pregnancy rate. So do look at the corpus luteum, do look at the endometrium on ultrasound. It is going to help you to decide what your luteal phase support is like and what it is going to be. It might help you to decide what kind of progesterone you want to give, although it may not be very helpful. However, depending upon the types of cases that I've described to you, I hope it has been helpful for you in deciding what you should be doing in the different types of patients that you get in your infertility practice. Thank you very much. God bless you all. Stay safe, stay at home. Thank you very much, IFS. Thank you very much, Dr. Sudha and Dr. Meena, for giving me this opportunity. Thank you very much, Bayer, Zydus, for giving for this academic support, and of course, DocMode for this wonderful platform, so that we can meet quite often, even in these difficult times. Thank you very much all for being here with me today.